Hello. I'd like to continue our discussion about preventative medicine, about these very important topics of identifying hypertension, identifying diabetes mellitus, and identifying and treating hypercholesterolemia and dyslipidemia in general. These are key for the prevention of the atherosclerotic causes of death, which includes the number one killer, heart disease. There are many screening tools available on the internet. Here is one from the government based on the Framingham study that estimates your risk of having a heart attack or a coronary death in the next 10 years. And what is it based on? It's based on your age. It's based on your gender. It's based on your lipid panel, your LDL, your HDL, your cholesterols. It's based on the it's based on your blood pressure, and it's based on if you're a smoker or not. And based on these things, you can estimate what your risk of having a heart attack is in the next 10 years if you're in the adult population. Very scary little slide. I recommend you playing around with it sometime. Okay? So basically, we can't change our gender. We can't change our age. But what are the modifiable risk factors for heart disease and atherosclerosis, atherogenesis? And they're smoking. That's right. We talked about how to stop smoking. The number two thing, we need to adjust our lipids. We need to get our LDL, low-density lipoprotein, down, right? We need to control the blood pressure. We need to treat, screen, and find diabetes. And if we control obesity and weight gain, guess what? The diabetes, the blood pressure, and the lipids will often take care of themselves. We'll go revert to normal. All right? So these are the important risk factors that we need to talk to our patients about. All right? Let's talk about the lipids a little bit. A typical lipid panel now consists of a fasting total cholesterol, a high-density lipoprotein, HDL, a low-density lipoprotein, LDL, and the triglycerides. Fasting means you haven't had any food outside of or drink outside of water for the past 8 to 12 hours. When do you screen? When do you do these lipid panel to screen patients for abnormalities? There's a wide range of opinion, but even pediatricians now understand that atherogenesis is a lifetime of indiscretion of eating and a lifetime of having abnormal lipids, and that even pediatric patients or adolescents can be screened. Certainly patients with positive family histories of heart disease and stroke need to be screened, and certainly by the time men reach their mid-30s, women in their mid-40s, patients should be screened for these abnormalities. Primary goal of therapy against the lipid panel is the LDL. The first thing you want to correct in a lipid panel is the patient's low-density lipoprotein. And the current guidelines are a little bit confusing and maybe a little bit too complex, but I want to go through them and teach you what the current guidelines are, okay? Okay? The current LDL recommendations is anywhere from 160 to 100. And they recommend patients have a target LDL that's different depending on what your other risks are of developing heart disease or peripheral vascular disease, right? Okay, so in this slide, CHD means coronary heart disease, meaning having a heart attack, right? CHD risk equivalents, that means things like peripheral vascular disease, other types of or stroke, other types of clogged artery, right? Or diabetes. Look how important diabetes is. If you have diabetes, your risk of developing future heart disease is the same as if you have already proven yourself to have coronary artery disease. It's the same as if you already had a heart attack. And for those patients, we're recommending LDL less than 100 is the target goal. Okay? All right? And if you have less risk factors for heart disease, they're recommending higher LDLs as an acceptable target range. But there's no question in anyone's mind, the lower your LDL, the less likely you are to have future problems with atherosclerotic diseases. Some cardiologists now are even recommending an LDL of 70 for patients who have had heart attack. So this is always changing a little bit. What are the risk factors to consider if you have to determine your LDL goal? So here we have the risk factors, how many you need for what LDL level, and here are the risk factors. If you smoke cigarettes, that counts as 1 point. If you have high blood pressure or take blood pressure medication, that counts as a point. If you have a low HDL, that counts as a point. Why? HDL is the good cholesterol. You want your HDL to be high, up above 40, and that will help prevent atherogenesis. Okay? If you have a positive family history, that is a risk factor. If you're older, well, if you're over 45 for men, that's a risk factor. Okay? Okay? So if you have more than 2 of these, then you want your LDL goal to be less than 130. Okay? Kind of confusing. I know. So think of it this way. If you've had a heart attack, or if you have some type of other sign of hardening of the arteries, you've got a stroke, you've got peripheral vascular disease, you've got diabetes, then you want your LDL to be less than 100. If you have a couple of risk factors, you just smoke, and you have high blood pressure but nothing else, then you want 130. If you have no risk factors or maybe one, then you'll accept an LDL of 160. Yes, I know it's complicated. Yes, I know. Okay? Okay? All right. Now, all patients, before you start medication, you need to discuss with your patients TLC, and that stands for therapeutic lifestyle change. All patients, if they're not at their target LDL, you need to talk to them about therapeutic lifestyle changes. And that means, what does that mean? Lose weight, exercise, eat your fruits and vegetables, no fatty foods, less red meat, less fats, less crackers, more whole grains, right? The normal dietary stuff. That is therapeutic lifestyle changes. And so for many patients, you may institute the therapeutic lifestyle changes and then have the patient come back at 2 months, 3 months, and repeat the lipid panel. And if they're still over their target LDL, then begin drug therapy. I've broken down each of these slides to discuss when to begin your therapeutic lifestyle changes. And basically, we see that for each category, you begin therapeutic lifestyle changes when their LDL is above the target LDL level. Is there really anybody that shouldn't eat their fruits and veggies and eat whole grains and not eat a lot of fats? No, everybody should eat right. So you can consider doing therapeutic lifestyle changes on all your patients when you counsel them about diet and exercise. Now, what medicine do we give first to lower the LDL? As a general rule, we give a statin drug, one of the statins. It lowers the LDL, and the statins have been shown to lower mortality the most. And since we're trying to prevent death, this is the perfect drug. Okay? So statins is the first line of drug. What are the side effects of statins? Well, you could have liver dysfunction. Patients can get jaundiced, so you monitor the liver function tests. And you should inform your patients if they ever get a lot of muscle pain. This can be a sign of rhabdomyolysis, and they should promptly call you for evaluation and treatment. Okay? What other class of medicines can you give for lipids? Okay? Cholestyramine will work. It's a bile acids, will bind in the bile acids. You can give gemfibrozole, and gemfibrozole will lower your triglycerides greatly, right? You can give niacin, Niacin will raise your HDL, right? Okay? And there's even some new medicines, such as Zetia, which is a new medication that prevents cholesterol absorption from the food that you eat. But the basic rule is you give one drug, it's usually the statin, because that lowers mortality the most. You raise the dose of the statin until you get the maximum effect, and then you see if you need to add any additional agent, a cholestyramine, a gemfibrozol, or a niacin. Okay? Okay? After we get the LDL controlled, the secondary targets is the HDL. We want HDL, good cholesterol, high, above 40. And the easiest way to do that is by diet and exercise. Okay? Right? We also would like to see the total cholesterol under 200. And finally, the triglycerides we'd like to see under 200 as well. And triglycerides are most easily controlled by diet and not eating a lot of crackers, that type of food. Okay? Now, blood pressure is also another risk factor for developing heart disease, right? Here's the normal blood pressure, 120/80. Okay? Prehypertension is considered up to 139/89, and stage 1 hypertension starts at 140/90. Okay? 50 million people plus have high blood pressure, and many people don't know about it since it's a asymptomatic disease until you have a complication like sudden coronary death, right? All right? The higher your blood pressure, the higher your risk of coronary vascular disease, CVD, coronary vascular disease. All right? All right? So it's a continuous thing. It's not that 120/80 is some type of magic number that makes you safe. For every elevation of 20 points systolic above 115, your risk of dying from heart disease is doubling. Okay? So the lower the better. Okay? Mm-hmm. If you have a patient with prehypertension, in the prehypertension range, and all patients with hypertension as well, you certainly want to concentrate on the therapeutic lifestyle changes. You want to discuss with them the importance of weight, the importance of smoking, the importance of eating right, the importance of obesity, and the importance of getting your weight down and exercise that will lower the blood pressure and decrease their chance of needing medication. You want to bring your patient's blood pressure down below 140/90. Okay? If you decrease it to that level, you decrease your incidence of stroke by 30-40%. Right? You decrease your chance of heart attack by 20-25%. And you decrease your chance of heart failure by a whopping 50%. So it's very important to bring your blood pressure down. Patients who already have diabetes or have chronic kidney disease, the target there is blood pressure even lower. There you want blood pressure 130/80. Okay? All right? So here's a nice graph that demonstrates what you possibly can do. And basically, if you're in the prehypertensive phase, you want to talk to them about therapeutic lifestyle changes and have them back. All right? But no drugs are generally given at this stage, unless there's some other problem. You know, perhaps they're diabetic, perhaps they have some other issue that needs medication. If they already had angina, you would give them medication. But as a general rule, there's no medicine here if they're a generally healthy patient. For stage 1 hypertension and stage 2, the first-line blood pressure medication is hydrochlorothiazide or a thiazide-type diuretic. And then, after that's been maximized, and they're doing the therapeutic lifestyle changes, if the blood pressure is still high, then you add another medicine. All right? And your choices are myriad. You can give an ACE inhibitor, an angiotensin receptor blocker, ARB, beta blocker, you can BB, beta blocker, you can give a calcium channel blocker, CCB. And somewhere in the test question for the test, they'll give you some reason to pick one drug over another, right? So if they tell you that the patient also has hyperthyroidism or they have some type of myocardial ischemia, well then certainly beta blocker would be a good choice. If they tell you they have some type of problem with heart failure, well maybe you're going to add lisinopril, ACE inhibitor. ACE is a very common second-line drug. Okay? If they tell you they had problems with ACE inhibitors and they swelled up and they have severe asthma and can't take beta blocker, well then maybe that would lead you to picking a calcium channel blocker for that individual patient. So there's a myriad of different classes of drugs to use as the second-line drug, and there'll be something in the stem of the question that pushes you one way or the other. A routine hypertension workup would include EKG, urine analysis for kidney function, BU and creatinine for kidney function. Don't forget your electrolytes, and don't forget your lipid panel. All right, diabetes, polydipsia, polyuria, polyphagia. Who should be screened for diabetes to see if they have the disease? All right? Certainly, people, when you get to be 40, 45, certainly by 45, you should start screening for diabetes at least a 3-year interval. Okay? Now, if you're overweight, if you have a BMI over 25, you're much more likely to have type 2 diabetes. So you would start screening at an earlier age, even in asymptomatic people, if the patient's overweight. And 60% of the adult population in the U.S. is overweight, meaning they have a body mass index, BMI, over 25. What's considered normal? If you're fasting, the glucose should be less than 100. If your fasting glucose is more than 126, you have the diagnosis of diabetes. Okay? Patients with metabolic syndrome. Metabolic syndrome is a combination of what? Abdominal obesity, hypertension, low HDL, high triglycerides, high LDL, high blood pressure, and an impaired glucose tolerance, maybe somewhere between 125 or frank diabetes, sugar over 126. That'd be metabolic syndrome. So patients that look like that, you'd also always want to check their sugar. Here's a slide that shows you how to calculate your body mass index. You're not going to have to do the math on the exam. You should just know that a body mass index over 25 means overweight. If your body mass index is over 30, that is obesity. Okay? And it's basically your height divided by weight controlled for the units. All right? And there's myriad sites on the internet where you can calculate your BMI if you want to give that a try sometime. So that leads us to the all-important obesity. How do you treat obesity? It's kind of like smoking in that you talk about the patient's weight every visit. You talk about the therapeutic lifestyle changes every visit. You talk about their nutrition, their need for smaller portions of food, the importance of eating fruits and vegetables and whole grains, the importance of not eating too many sweets and fried and fatty foods, the importance of exercise, at least 20 minutes 3 times a week of walking. And that's the main issue. You can refer the patients to dietitians. You can screen them for depression. Perhaps the patient has an eating disorder, right? Patients that eat uncontrollably and have a sense that they're not in control of their eating have eating disorders. Okay. There's also medication that you can use for obesity, which are approved. They don't seem to be the greatest, but they work for some patients. One is Meridia, sibutramine. This is a generic. And this is an inhibitor of norepinephrine and serotonin. So, the side effects here are hypertension and tachycardia. And since so many patients who have obesity already have hypertension, it's not a very good choice for those patients. It's going to make their blood pressure go even higher. Another drug that's approved on the market for the treatment of obesity is orlistat, marketed as Xenical. And this stuff inhibits your pancreatic lipases. So It prevents the absorption of fats and fat-soluble vitamins. It gives you steatorrhea. It gives you, frequent uncontrolled urge to defecate of kind of oily, slimy stool. I mean, this does not sound like fun. So most of the treatment of obesity is still counseling, diet and exercise, and it's really a lifestyle change, not that I'm going on a diet for 3 months, I'll lose the weight and then stop. It's a commitment to a lifestyle change for the rest of your life. Okay? Who is the gastric bypass surgery reserved for? Those are patients with BMI over 40. And these patients are going to have B12 deficiency, and there's a very high incidence of complications just from the surgical procedure, as there's higher risk from anesthesia and blood clots, pulmonary embolism, DVT, and recovery from the surgery when you're very overweight. Thank you. That is the conclusion of the hypertension diabetes section.